Today's session is basically Harrison's through a biochemist lens, and the topic is hyponatremia. I thought I should take this up. We are discussing Harrison through a biochemist lesson, basically because I see that there is a shift from the way a subject is being taught and read. There is a shift from concept-based learning to a factual learning. And I always say this: factual learning will not take you very far. It neither helps you in retention nor does it help you in application. And only because basic sciences, I would not say anatomy, physiology, biochemistry as basic sciences to begin with. All these subjects are bridges, which will help you in understanding all clinical subjects. So only because these basic sciences are not being learned properly and conceptually, we find it difficult. The Bible of medicine, which is Harrison. So I thought I should give you a brief on how these subjects should be perceived. So this discussion will be a conceptual discussion on hyponatremia and basically how to make a diagnosis of a case of hyponatremia. So objectives of this session would be: number one, to define hyponatremia. When do you say it is low sodium? That would be my first objective. And then I'll tell you about the clinical features of hyponatremia. Then I would like to classify hyponatremia so that it's easy for you to make a diagnosis of the possible cause of hyponatremia. And finally, I'll give you a summary of all these. These are the objectives of this session. So to begin with, normal values for sodium. We know sodium normal value is 136 to 145 milliequivalents per liter. So what is hyponatremia? Before we discuss what is hyponatremia, why are we worried about sodium homeostasis? Why do we have to maintain sodium values within this narrow range of 136 to 145? It's basically because, so we know sodium is osmotically active, and until sodium is present in your circulation, it holds water within the circulation. So what is expected when there is sodium imbalance? When there is hyponatremia, it cannot hold water. The circulation cannot hold water. So water moves from the circulation into the cell, first into interstitial fluid, and then it gets into the cell. So basically what you expect in hyponatremia is cell swelling. And this is observed as cerebral edema in extreme cases, and even pulmonary edema, non-cardiogenic pulmonary edema. This is what we expect in hyponatremia. Now, in extreme cases, you observe it as cerebral edema. What do you observe in between? Are you going to find clinical features even when the sodium value is less than 135 milliequivalents per liter? Answer is not always. So whether you find clinical features or not would differ depending upon the onset of hyponatremia, whether it's an acute onset or a chronic onset. Acute onset is development of hyponatremia within a period of 48 hours, in which case you're going to observe symptoms. And if it's severe, what is severe hyponatremia? If it's less than 120 milliequivalents per liter. So in one of these cases, you're going to find extremes of manifestations. If acute hyponatremia is developed within 48 hours, or hyponatremia wherein the value is less than 120 milliequivalents per liter, in these cases, you'll observe manifestations of cerebral edema in the form of seizures, convulsions, or it can present as respiratory depression, it can present as coma, it can present as pulmonary edema. Now, if there is mild decrease in sodium, mostly it is asymptomatic. And when it's further low, it presents with non-specific manifestations like increase in the fall rate. There can be abnormalities in the, there can be cognition difficulties. All these are non-specific symptoms. And when it falls even below this expected value, what you observe is confusions, irritability. The person might complain of nausea, vomiting. So all these are non-specific manifestations to begin with. So mild hyponatremia presents as alteration in gait, frequent falls, cognition difficulties, irritability. Further down, presents with nausea, vomiting, disorientation, aggressiveness. Only when it is severe hyponatremia, it presents with seizures, coma, respiratory depression, and pulmonary edema. So these are the clinical features of hyponatremia. Now, what are the types of hyponatremia? So I said the normal value of sodium is between 136 and 145 milliequivalents per liter. Does that mean whenever you find serum sodium value to be less than 135 milliequivalents per liter, it's always true hyponatremia? Not necessarily, because interestingly, we have one condition called as pseudo-hyponatremia. So what is pseudo-hyponatremia? This is observed in two conditions. When I say pseudo, it means you don't have to react to it. Yeah, it's a false decrease in sodium and you don't have to react to it. That's what we mean by pseudo-hyponatremia. And this is observed in two conditions. Yeah, one is presence of osmotically active solutes in the solution. Yeah, presence of osmotically active solutes in the circulation, in which these solutes attract water into the circulation, and this water dilutes the circulation and that causes a decrease in sodium. So we call this condition as dilutional hyponatremia. Do you understand this? You call this as dilutional hyponatremia. Most common cause would be hyperglycemia. So what happens in hyperglycemia? The excess glucose being osmotically active attracts water and this dilutes the circulation. That causes a false decrease in sodium. Why am I saying that this is a false decrease in sodium? It is because you don't have to react to it. You don't have to react to the fall in sodium. All that you will have to do is decrease the glucose level. The sodium level will normalize. Okay, so this is one example. Another example for this is mannitol infusion. Yeah, mannitol infusion or presence of radio contrast dyes. Yeah, presence of radio contrast dyes. So in all these conditions, you don't have to treat the saline. You don't have to even ask the person to restrict water intake. All that you will have to do is you will have to treat the underlying cause. If there is hyperglycemia, just correct the glucose level. Reason being the sodium has not come out of the system. The sodium is very much within the system. It's just a dilution which has caused a false decrease in sodium. So this is called as dilutional hyponatremia. What are the causes of dilutional hyponatremia? I told you. One is hyperglycemia, then mannitol infusion or radio contrast dyes. Okay. Now there is another scenario wherein pseudo hyponatremia might be observed, and this is basically a measurement defect. And as far as sodium measurement is concerned, till some time back we were using flame photometry. Yeah, we were using flame photometry for sodium estimation. These days we don't use flame photometry, we use ion selective electrodes. Yeah, we use ion selective electrodes for sodium estimation. And there are two types of ion selective electrodes. One is direct ISE, the other one is indirect ISE. And all that you have to know is in indirect ISE, we dilute the serum. Yeah, we dilute the serum in the ratio 1:10, and then we estimate the sodium value and then we multiply it by 10. Yeah, that's what we do in indirect ISE. In that case, if there is a condition like hyperlipidemia, yeah, hyperlipidemia or hyperproteinemia, when you take 10 serum and you're diluting it, in the 10 microliter, maximum volume is occupied by the protein. For example, multiple myeloma. Yeah, paraproteinemias, wherein out of the 10 microliter of sample that you have taken, maximum volume is occupied by that paraprotein or by the lipid. So when you're diluting, you think you have diluted it as 1:10, but you have diluted it more because the major solid component has occupied the volume. So there is over dilution that happens, because of which there will be a false low value. Okay. What are the causes of pseudo? One is hyperglycemia, mannitol infusion, which is dilutional hyponatremia. The other one is a measurement effect, which happens only when it is estimated, only when sodium is estimated by indirect ISE. And in indirect ISE measurement, there is an abnormality of sodium value that is observed whenever there is hyperlipidemia. Whenever there is hyperlipidemia or whenever there is hyperproteinemia. Now you can't go, yeah, being a clinician, if you're a clinician, you can't go to the lab and ask, are you using indirect ISE because I found low sodium, I want to know if it's a true hyponatremia or pseudo-hyponatremia. You can't go back to the lab and ask if it's an I'm telling you, there are many instruments which use indirect ISE. So you can't go back and ask this. So as a clinician, you should have a way of finding out whether it's true hyponatremia or pseudo-hyponatremia. That differentiation can be done by measuring osmolality. Yeah, the differentiation can be done by measuring osmolality. So I'm going to give you an introduction to osmolality, for which you have to know what is osmosis. So what is osmosis? Osmosis is movement of solvent. Yeah, the water part. It is movement of solvent from a solution of lesser or lower impermeable solute concentration to a solution of higher impermeable solute concentration. Do you understand this? Osmosis is movement of solvent from a solution of lower impermeable solute concentration to a solution of higher impermeable solute concentration, raising the level of the fluid on the side where you have more impermeable solutes. Okay, so are you worried about such osmotic movements in your body? Yes. Suppose in the circulation there is an impermeable solute that has accumulated. It is going to cause movement of water from the cell into the interstitial fluid and then into the vascular fluid. And that is going to, right? It's going to cause volume overload in the circulation. So yes, you are worried about such osmotic movements. Now to get an idea of possible osmotic movements that's happening in a person, you have to measure the number of impermeable solutes present in the circulation. And that is why you're going for a measurement of osmolarity and osmolality. Are you counting? What is osmolarity and what is osmolality? You know, osmolarity and osmolality are basically the number of osmotically active solutes. You know that, right? It's basically the number of osmotically active solutes. If it's osmolality, L, yeah, if it's osmolality, it is number of osmotically active solutes per kilogram of solvent. If it's osmolarity R, it is number of osmotically active solutes present per liter of the solution. Right? This between osmolarity and osmolality, but as far as serum or plasma is concerned, you don't have to worry about whether it's osmolarity or osmolality. Both terms can be used interchangeably. Okay, so now I'm going to tell you how do we calculate osmolality of serum. There are two ways in which you will know osmolarity or osmolality of a person. One is calculating osmolality, the other one is measuring osmolality. Now, calculated osmolality is calculated using a formula 2 into sodium. Yeah, the formula is 2 into sodium plus glucose concentration by 18 plus blood urea nitrogen by 2.8. So what is the formula? So the formula for measuring osmolarity, the formula for calculating osmolarity or osmolality is 2 into sodium plus glucose concentration by 18 plus blood urea nitrogen by 2.8. So I've given you this in the PowerPoint. So this is the formula. Okay, so if you ask me why do I have to use this formula? Because you know so is osmotically active solute that is present in the circulation, agreed. But why do you multiply it by 2? We multiply it by 2 because sodium would not have been there as just Na plus. It would have sodium chloride, bicarbonate, which would have dissociated into Na plus and corresponding anions. So instead of you measuring the cation separately and anion separately, it is more wise if you measure the major extracellular cation, which is sodium, and if you multiply it by 2, it means you have taken into account the effect of anions as well. So what is the reason for the first component of the formula 2 into sodium? It means you have included the effect of not only sodium but also of corresponding anions. That's why 2 into sodium. Now why is it glucose by 18? It is because you want the number of glucose molecules present in the circulation, not the weight of glucose. And whenever you measure concentration of glucose in your blood, it is milligram per deciliter. That's how you express glucose concentration, as milligram per deciliter. You don't want the weight, but you want the number. So to convert weight into number, you divide it by molecular weight. That is why you have divided it by 18. Same is the reason for blood urea nitrogen by 2.8. So what is the formula for calculating osmolarity or serum or plasma? It is 2 into sodium plus glucose concentration by 18 plus blood urea nitrogen by 2.8. But this formula is not wholesome. It's not a complete formula. Reason is you have just assumed that sodium, the corresponding anions, you have just assumed that sodium, the corresponding anions, glucose and blood urea nitrogen are osmotically active. You have just assumed that. What if there are some other solutes that have got added to the circulation which are causing osmotic movements? For example, what if ketoacidosis, and this diabetic ketoacidosis has added ketone bodies to the circulation? That will cause osmotic movement, which you're going to miss because you don't have a provision to include ketone body concentration in this formula. So the defect or the limitation of calculating osmolality is it uses only the effect of normal solutes. It does not include the effect of abnormal solutes. Yeah, for example, mannitol infusion. A person would have undergone mannitol infusion because of which osmolality could have increased, but if you're calculating, you are going to miss it. That is why if you find a case of hyponatremia and you're trying to find out a cause for which you want osmolality, please mention that you want measured osmolality. Do you understand this? You will have to mention that you want measured osmolality. You don't want a calculated osmolality. So when you mention that you want measured osmolality, they measure it using an equipment called as osmometer. And this osmometer is based on freezing point depression. It is based on freezing point depression, and this will clearly this will give you exactly the osmolality of serum or plasma of the person. Okay. Now tell me, what do you expect about osmolality value of a person in hyperglycemia? In hyperglycemia, what would happen? There is an increase in glucose, so the osmolality value will be elevated. The person has underwent mannitol infusion. What will happen to osmolality? It will be again elevated. Radio contrast dye, osmolality will be elevated. So in all dilutional hyponatremia conditions, serum osmolality will be high. What happens if it's a pseudo-hyponatremia caused by indirect ISE measurement? Yeah, if it's because of indirect ISE measurement, what are the causes I told you? I said it is hyperlipidemia or it is because of hyperproteinemia. Lipids and proteins are not osmotically effective. So in both hyperlipidemia and hyperproteinemia, if you measure osmolality, it will be normal. Yeah, osmolality will be normal. So you find the case of hyponatremia. So you find the case of hyponatremia. Yeah, you want to know whether it is true hyponatremia or pseudo-hyponatremia. If it's true hyponatremia wherein the sodium value is low, measured osmolality will be definitely low. Do you understand this? Measured osmolality will be definitely low. Whereas if it's pseudo-hyponatremia, which is caused either by dilutional hyponatremia or because of measurement, I won't say defect, it's measurement effect, osmolality will be either high or normal. Okay, so you come across a case of hyponatremia, then you're estimating osmolality. If osmolality is also low, then you know that it's a case of true hyponatremia. In contrast, if osmolality happens to be high, low sodium, high osmolality, it's dilutional hyponatremia caused by hyperglycemia or radiocontrast dye infusion or mannitol infusion. Low sodium is accompanied by normal osmolality. It's a pseudo-hyponatremia dilution effect. It is mostly because of hyperlipidemia or it is because of paraproteinemias. Yeah, so this is the first level. Pseudo-hyponatremia, osmolality is either high or osmolality is normal. Only in true hyponatremia, osmolality will be less. So does that mean in hyperglycemia, you won't know whether it is hyponatremia or not? Because as such, hyperglycemia can also cause hyponatremia, right? So hyperglycemia. Do you think hyperglycemia always causes pseudo-hyponatremia? No. Because, you know, it can even cause true hyponatremia. Why will it cause true hyponatremia? Whenever hyperglycemia causes osmotic diuresis. Yeah, whenever it causes osmotic diuresis, along with water, sodium also gets lost, in which case it's true hyponatremia. So please don't think, okay, I've estimated sodium level, it is low. Then I know this is accompanied by high glucose, which means it's only pseudo-hyponatremia. You should also think that there is a possibility of true hyponatremia. So to differentiate pseudo-hyponatremia and true hyponatremia in hyperglycemia, you should always find out the corrected sodium. What is the sodium when the dilution factor is removed? Yeah, that is corrected sodium. And for this, you should remember that for every 100 milligram per deciliter increase in plasma glucose above the normal value, yeah, for every 100 milligram per deciliter increase in plasma glucose above the normal value, serum sodium will be decreased falsely. Yeah, serum sodium will be decreased falsely by 1.6 milliequivalents per liter. And if the serum glucose is more than 400, if the glucose is more than 400 milligram per deciliter, for every increase in 100 milligram per deciliter of serum glucose, sodium will be decreased by 2.4 milliequivalents per liter. Do you understand this? So corrected sodium. Purpose of you having to calculate corrected sodium to find out whether there is just a pseudo-hyponatremia in hyperglycemic condition, or is it a true hyponatremia, for which you should do a correction factor. Corrected sodium is calculated based on the fact that for every 100 milligram per deciliter increase in plasma glucose above normal value, serum sodium will be falsely decreased by 1.6 milliequivalents per liter if the glucose value is less than 400 milligram per deciliter. If the glucose is very high, beyond 400 milligram per deciliter, for every 100 milligram per deciliter increase in glucose, serum sodium is falsely decreased by 0.4 milliequivalents per liter. I'll give you an example. Yeah, plasma glucose of a person is estimated, and it happens to be 900 milligram per deciliter. This is random glucose. Yeah, random plasma glucose of a person happens to be 900 milligram per deciliter. Serum sodium of this person is say 133 milliequivalents per liter. Will you immediately start correcting the sodium? You should not immediately start correcting sodium because you know there is a dilution factor because of which the serum sodium might have been reduced falsely. So how will you correct the sodium? I said for every 100 milligram per deciliter increase above normal. What is a normal random plasma glucose? 140 milligram per deciliter. Less than 140 is normal. So above 140, how much has it increased? It has increased by 760 milligram per deciliter. And I said for every 100 milligram per deciliter, the increase is calculated. Okay. So how many 100 milligrams per deciliter has it increased? It has increased 7.6 hundredths. Right? Yeah, 7.6 times. And I said for every 100, beyond 400 milligram per deciliter, if the value is more than 400, for every 100, it has to be increased by 2.4. So for 7.6 hundredths, it will be increased by 2. Right? So 7.6 into 2.4. Let me calculate it approximately. 8 into 2.4 will be 319. So you should correct the sodium by 19 milliequivalents per liter. So if the calculated value is 133, what is the actual sodium in that person? 133 plus 19 will be 152. So actually the person is suffering from hypernatremia. It is not hyponatremia. So what is the carry home message here? The carry home message here is sodium values which are estimated. Sodium value which is estimated cannot be taken at face value. Okay, that there can be conditions when you will have to correct it. One such scenarios is whenever there is a presence of hyperosmotic solute. For example, glucose. Yeah. So what is the effect of glucose? Glucose being osmotically active, until it's present in the circulation, it attracts water, it causes dilution. And because of this dilution, sodium values falsely low. Why am I saying it's falsely low? Because the sodium has not come out of the system. The sodium is very much there. And once you correct the glucose value, the sodium value will be brought back, which means you should not be starting saline. You should not ask the person to withhold water intake. Water restriction should not be recommended. All that you will have to do is correct the glucose value. Okay. And you should also know that there are conditions wherein hyperglycemia can cause true hyponatremia. Whenever there is osmotic diuresis, there can be true hyponatremia. So when you estimate sodium values in a person with hyperglycemia, if it happens to be low, you will have to correct the sodium. In the sense, you will have to correct the dilution effect caused by the glucose and see whether it's normal, low or high. And how will you correct it? Above normal plasma glucose. Above normal plasma glucose, for every 100 milligram per deciliter increase in plasma glucose, serum sodium will be falsely decreased by 1.6 milliequivalents per liter. Yeah, if it's even high, if it's more than 400 milligram per deciliter, serum sodium has to be corrected by what factor? 2.4 milliequivalents per liter for every 100 milligram per deciliter increase in sodium. And that's what I've given you an example. Yeah, I've given you an example for that. Suppose a person's plasma glucose happens to be 900 milligram per deciliter. If it's random plasma glucose, normal value is 140. So from 140, how much has it raised? It has raised 760. It has raised by 760 milligram per deciliter. For every 100 milligram I said the increase is going to be 2.4 milliequivalents per liter. So for 760 milligram per deciliter increase, this is how we need to calculate, right? For 100 milligram per deciliter increase, serum sodium will be decreased by 2.4. So for 760 increase, how will you calculate it? It's going to be 2.4 into 7.6. So I had it roughly as 2.4 into 8. I got it as 19.2. So falsely, the sodium is decreased by 19.2 milliequivalents per liter, which you have to add to the value that is measured. I said the measured value is, what is the value we gave? 133. So from 133, if I increase it by 19, it actually becomes 152. So the person is actually suffering from hypernatremia. But if you just look at serum sodium value, the value that you directly get it, you might think it's hyponatremia. So this is the significance of you knowing about pseudo-hyponatremia, a condition which exists. So that's all about pseudo-hyponatremia. Okay, this is what I told you in detail. Now about true hyponatremia. Now we have types of true hyponatremia, and this classification can be based on the hydration status of a person. To find out the cause of true hyponatremia, the first aspect which you should observe is hydration status. How will you check for hydration status of a person? You can look for JVP, you can look for heart rate, you can look for BP, blood pressure, you can look for signs of increase in blood, for increase in volume. For example, pedal edema. Look for signs like pedal edema, ascites, yeah, pulmonary edema. So if you have a look at all these, you just observe all these of a person's skin turgor. So if you look for all these signs, you will know whether the person is euvolemic or if the person is hypovolemic or if the person is hypervolemic. So based on this, we are going to classify true hyponatremia. Basically, you should look at pulse, blood pressure, jugular venous pulse, signs like pedal edema, presence of ascites, pulmonary edema. Okay, so based on this, we classify hyponatremia three types. One is hypervolemic hyponatremia, second one is euvolemic hyponatremia, and the third one is hypovolemic hyponatremia. So when will you call it as hypervolemic hyponatremia? When you see that the jugular venous pulse is raised, or when you find signs like pedal edema, ascites, pulmonary edema, you see blood pressure to be high. So in all these conditions, you call it as hypervolemic hyponatremia. And example for this would be congestive cardiac failure, liver cirrhosis, nephrotic syndrome, chronic kidney disease. So what is common in all these conditions? In all these conditions, there is a movement of fluid. Yeah, there is movement of water from the vascular compartment into the interstitial space. In all these conditions, there is movement of fluid from the vascular compartment into the interstitial space. And this would cause two effects. One is hypovolemia. Yeah, in the sense there is decrease in the blood volume within the circulation. Yeah, so there is hypovolemia and there is increase in osmolality. So what are the two effects you observe in all these conditions? There is decrease in the blood vessel volume. The blood volume is decreased and there is increase in osmolality. Now, what happens whenever there is hypovolemia and hyperosmolality? To understand the effects, there are two background conditions you need to know. One is about JG apparatus and the other one is about vasoreceptors. So first about JG apparatus. I'm not going to get into the details of JG apparatus. I want you to just know that there are three components of JG apparatus. The first one is JG cells, second one is macula densa, and the third one is Lassus cells. And for this topic of discussion, I'm going to tell you only about JG cells. JG cells are modified afferent arteriolar cells. Yeah, they are modified afferent arteriolar cells, and they are basically baroreceptors or volume receptors. And they get activated whenever there is a decrease in the afferent arteriolar pressure. Yeah, they get activated whenever there is a decrease in the afferent arteriolar pressure. And when they get activated, they release renin. JG cells release renin. And this renin forms angiotensin 2, helps in the formation of angiotensin 2. And angiotensin 2 causes aldosterone secretion. Aldosterone causes an increase in sodium and water reabsorption. An increase in sodium and water reabsorption will cause a counteractive effect here, in the sense the afferent arteriolar pressure will become normal now. Do you understand this? If you are ultimately asked what is the function of JG apparatus, you should say it retains water. It retains sodium. Do you understand this? JG apparatus is to retain sodium and to retain water. In that case, what should be the stimulus? A decrease in the volume. So for any reason, whenever there is a decrease in the intravascular volume, afferent arteriolar pressure decreases. That stimulates JG cells, and JG cells release renin. Renin produces angiotensin 2. That causes aldosterone secretion, and that increases sodium and water reabsorption, restores the intravascular volume. Yeah, so this is about JG apparatus. Now about osmoreceptors. Osmoreceptors are present in the anterior hypothalamus. Yeah, they are present in the anterior hypothalamus, and they get activated whenever there is hypovolemia or whenever there is hyperosmolality. Whenever the osmolality of a person's serum increases above 285 milliosmoles per kilogram, even when it rises above 285 milliosmoles per kilogram, the anterior hypothalamus receptors get activated. And when they get activated, they bring about their actions through OVLT. They bring about their actions through OVLT. So organum vasculosum of lamina terminalis, that is its name, right? It is organum vasculosum of lamina terminalis, and it's one of the circumventricular organs. Okay, now listen to me carefully. For your understanding of function of OVLT, I'm going to abbreviate it in a different way. Okay, so OVLT is abbreviated as O stands for osmoreceptor mediated stimulation. Yeah, O stands for osmoreceptor mediated stimulation of. V stands for vasopressin secretion first. Yeah, vasopressin secretion first. LT stands for later on thirst. I have abbreviated OVLT as osmoreceptor mediated stimulation of vasopressin secretion first, later on it stimulates thirst, which means whenever there is hyperosmolality, osmoreceptors in anterior hypothalamus get stimulated, and they stimulate vasopressin first, and then they stimulate thirst. Don't you want this to happen? Because when vasopressin is secreted, you know, vasopressin causes water reabsorption, right? Vasopressin causes water reabsorption. That's hyperosmolality. Then you feel thirsty, right? When you feel thirsty, you drink water. That also arrests hyperosmolality. Okay, so these are the two things I want you to know to understand what happens in hypervolemic hyponatremia. So in hypervolemic hyponatremia, wherein I gave you an example. What are the examples I gave you? Congestive heart cardiac failure, liver cirrhosis, nephrotic syndrome, chronic kidney disease. In all these conditions, there is a shift of fluid from the intravascular compartment into the interstitial fluid. And because of this, there is a reduction in the intravascular volume, and there is an increase in the osmolality. And decrease in the intravascular volume, the apparatus to get stimulated. Increase in hyperosmolality stimulates osmoreceptors in the anterior hypothalamus. First, what happens when JG apparatus gets stimulated? As I said, 2 is produced, aldosterone is released, And aldosterone causes sodium and water reabsorption. So to start with, there is an increase in sodium and water reabsorption in all these conditions. But in due course, when anterior hypothalamus stimulates OVLP, OVLP stimulates vasopressin secretion, and this vasopressin increases free water reabsorption. So on one hand, there is sodium and water reabsorption. On the other hand, there is only water reabsorption. So predominantly water is getting reabsorbed more and more than sodium reabsorption. So that causes hyponatremia. Do you increase in more free water reabsorption? Because on one hand, sodium and water gets reabsorbed, in which case sodium level will not be altered. But simultaneously, vasopressin causes an increase in only water reabsorption. So that causes an increase in free water reabsorption, and that causes hyponatremia. So now do you understand why there is hypervolemic hyponatremia? This hypervolemic hyponatremia is mainly because an increase in renin, angiotensin, aldosterone system, and it's because of an increase in vasopressin. And in all these conditions, can you tell me about urine sodium? This causes a reduction in serum sodium. What do you think of urine sodium in all hypervolemic hyponatremia conditions? I'll give you a clue. There is an increase in sodium and water reabsorption. Sodium reabsorption is increased. So urinary sodium will be less. Urinary sodium will be less than 20 milliequivalents per liter in all hypervolemic hyponatremia conditions. Now about euvolemic hyponatremia. So when will you find euvolemic hyponatremia? The most common cause would be, or the most well-known cause would be syndrome of inappropriate antidiuretic hormone. SIADH is a form of euvolemic hyponatremia. And apart from that, hypothyroidism also presents as euvolemic hyponatremia. And the third example for euvolemic hyponatremia is psychogenic polydipsia. Okay, so these are the three causes of euvolemic hyponatremia. First, let me tell you about SIADH. And for you to understand about SIADH, you need to know about the effect of vasopressin on water reabsorption. I want you to know that vasopressin has got an effect on water reabsorption only in the late DCT and collecting ducts. Okay, it has got an effect in water reabsorption only in late DCT and collecting ducts, wherein vasopressin acts on D2 receptors to cause aquaporin insertion. It causes upregulation of aquaporin 2 channels along the apical side of late DCT and collecting ducts. And through these aquaporin 2 channels, it increases water reabsorption from 2%, which happens in late DCT and collecting ducts in the absence of vasopressin, to 14.99% in the presence of vasopressin. Okay, vasopressin has got no effect on water reabsorption in proximal convoluted tubule, no effect in any limb of loop of Henle, no effect in early DCT. Do you understand this? So where does vasopressin act? It acts only on the late DCT and collecting duct cells when it causes aquaporin 2 insertion into the apical side, and through these aquaporin 2, it increases 2% of water reabsorption, which usually happens there, to 14.99%. That's about effect of vasopressin. And what are the stimuli for vasopressin secretion? Vasopressin causes water retention, like hypovolemia and hyperosmolality. Do you understand this? The two stimuli for vasopressin secretion would be hypovolemia and hyperosmolality. Now, what is syndrome of inappropriate antidiuretic hormone secretion? It is excessive vasopressin secretion, which is unsuppressible by hypervolemia and hypoosmolality, and it's secreted either pituitary or it can be from an ectopic source. Do you understand this? It's inappropriate, right? What does inappropriate mean? Even when there is hypervolemia, even when there is hypoosmolality, it is getting secreted. So what is the definition for syndrome of inappropriate antidiuretic hormone? It is excessive vasopressin, which is unsuppressible by hypervolemia and hypoosmolality and secreted either from posterior pituitary or it can be from an ectopic source. Now, what are the causes of SIADH? The causes are related to the central nervous system. So, central nervous system causes include meningitis, yeah, or encephalitis, or subarachnoid hemorrhage. And as far as subarachnoid hemorrhage is concerned, it can cause either SIADH, and on the other hand, it can also present as cerebral salt wasting syndrome. Yeah, cerebral salt wasting syndrome. Why am I telling you about this? Because both SIADH and cerebral salt wasting syndrome will present as hyponatremia. And you will have to differentiate the two conditions because the treatment for these two conditions would be different. Do you all know that for SIADH you recommend water restriction? Yes, right? For SIADH we ask the person to restrict intake. Whereas for cerebral salt wasting syndrome, we ask the person to take adequate fluids. So you will have to differentiate the two conditions. So remember, if a person has got subarachnoid hemorrhage and you find hyponatremia, don't immediately say, okay, this person has got SIADH. The hyponatremia hemorrhage can be either because of SIADH or it can be because of cerebral salt wasting syndrome. And you can differentiate the two conditions just by checking the urine output. Most commonly in SIADH, urine output will be normal or less. In cerebral salt wasting syndrome, urine output will be high. The treatment for these two conditions will be different. For SIADH, it's water restriction. For cerebral salt wasting syndrome, you ask the person to take adequate fluid. This is about CNS causes. Then it can be an ectopic source of vasopressin. Most common ectopic source of vasopressin is observed in small cell carcinoma of lung. Small cell carcinoma of lung. It's also observed in mesotheliomas, stomach cancer, pancreatic cancer. So that's about ectopic source. Or it can be because of drugs. Pulmonary cause, yes, pneumonia can present as SIADH. And then what are the drugs which present as SIADH? This has been asked so many times, right? Vincristine presents as SIADH, chlorpropamide, SSRI, antidepressants, SSRIs, many of those drugs present with this, and then recreational drugs, ecstasy. Yeah, ecstasy drugs, amphetamines, MDMA. Ecstasy is MDMA. It is an amphetamine. Basically, it presents as SIADH. And then oxytocin. Please remember, oxytocin can cause hyponatremia. And the reason for oxytocin presenting with hyponatremia is cross-reactivity of oxytocin with vasopressin receptors. Yes, it presents as SIADH and it presents as euvolemic hyponatremia. So that's about drug causes of SIADH. And then it can be because of a congenital defect, genetic defect wherein the vasopressin receptors are hyperfunctioning. Possible in the presence of sarcoidosis. So these are the causes of SIADH. So CNS causes include meningitis, encephalitis, subarachnoid hemorrhage. Ectopic cause most commonly it's small cell carcinoma of lung or mesothelioma, stomach cancer, pancreatic cancer. Pneumonia presents as SIADH. Drugs vincristine, chlorpropamide, SSRI, ecstasy, oxytocin, and then sarcoidosis. Now, what is the mechanism of hyponatremia in SIADH? That you will all understand, right? SIADH presents with hyponatremia because vasopressin causes free water reabsorption. More and more water is getting reabsorbed. So naturally it causes a low sodium. But what you might not understand is how does it present as euvolemic hyponatremia where it causes water reabsorption. It is because whenever vasopressin is increased, there is increased free water reabsorption that causes, and whenever there is volume overload, atria gets stretched. And atrial stretch receptors release atrial natriuretic peptide. Okay, not just that. Whenever there is volume overload, what happens to JG apparatus? Volume overload. Afferent arteriolar pressure is increased. So JG apparatus is suppressed. Right? So what happens to renin-angiotensin system? It is suppressed. So atrial natriuretic peptide causes natriuresis. Suppression of renin system also causes natriuresis. So what do you observe here? Antidiuretic hormone does not allow diuresis. This natriuresis causes diuresis. So the effect of antidiuretic hormone is compensated by atrial natriuretic peptide release and by suppression of renin-angiotensin system. So water is compensated, water retention is compensated by water excretion. But in addition, there is natriuresis. In addition, we are losing sodium. Yeah, so that causes hyponatremia. Do you get it? This causes hyponatremia. Now, what do you think of urine sodium in this condition? What do you think of urine sodium in this condition? I said in hypervolemic hyponatremia, because of the secondary hyperaldosteronism, which causes sodium reabsorption along the renal tubules, I said urine sodium is less than 20. But in this case, there is natriuresis and a concentrated urine. So what do you think of urine sodium? It will be more than 20 milliequivalents per liter. Okay, so this is about SIADH. So I want you to know that mostly hyponatremia presents with a decrease in urine sodium. Do you understand this? Hyponatremia mostly presents with a decrease in urine sodium. Exceptions are when sodium is lost through kidneys. Logically, right? Exceptions are when sodium is lost through kidney. Example will be diuretic. Obviously, right? If the hyponatremia is because of diuretic usage, urinary sodium is going to be more than 20 milliequivalents per liter. Or it can be because of aldosteronism, addisons. Yeah, it can be because of hypoaldosteronism or addisons. What happens in addisons? Low aldosterone. Without aldosterone, sodium and water is not getting reabsorbed. Sodium and water are getting lost in the urine. So there is hyponatremia and increase in urine sodium. Okay. And so this is one category. Yeah, in all these conditions, sodium is lost through kidney. Example, diuretics, chronic kidney addisons. And the second category is whenever there is an increase in the free water reabsorption. Increase in free water reabsorption, urine becomes concentrated. So urine sodium becomes higher. So that is SIADH. So this will help you in arriving at a differential diagnosis of hyponatremia. Do you understand this? You find a person with hyponatremia, you're asking for urine sodium. If urine sodium also happens to be low, it is one of the hyponatremic conditions which are associated with secondary hyperaldosteronism, like hypervolemic hyponatremia or hypovolemic hyponatremia. Whereas if you find serum sodium to be low, and if that is associated with a decrease in urine sodium also, yeah, it means when decrease in serum sodium that's accompanied by an increase in urine sodium, then you should think of conditions wherein sodium is lost through kidney. So what are the conditions wherein sodium is lost through kidney? It can be diuretic, or it can be a chronic kidney disease patient, or it can be a patient of addisons, or whenever there is an increase in free water reabsorption, as which happens in SIADH. Okay. So how do you diagnose SIADH? How can we diagnose SIADH? It's syndrome of inappropriate antidiuretic hormone secretion. Antidiuretic hormone secretion is high. Okay, let me ask you a straightforward question. Will antidiuretic hormone help in making a diagnosis of syndrome of inappropriate antidiuretic hormone secretion? Answer is no. Answer is no. Because in all other conditions which I mentioned before, for example, in hypervolemic hyponatremia, again vasopressin is secreted more, right? But those are appropriate antidiuretic hormones. All forms of hyponatremia, there will be excess antidiuretic hormone secretion, but those are all appropriate antidiuretic hormone secretion. This is inappropriate antidiuretic hormone secretion. So estimating ADH levels alone will not tell you whether it's inappropriate or appropriate antidiuretic hormone secretion. Okay, so this is not going to help. So diagnosis of SIADH is purely by suspicion and exclusion. So when will you suspect SIADH? Whenever serum sodium is less. Whenever serum sodium is less than 135 milliequivalents per liter, I'm going to suspect SIADH. And what are the other conditions which will tell me that's probably SIADH is? I will estimate first osmolality. Whenever I see hyponatremia, what am I going to look for? Osmolality to rule out pseudo-hyponatremia. So when I estimate osmolality in SIADH, it's going to be less. Yeah, serum hypoosmolality. And then I look for the hydration status of the person. For me to say that it's SIADH, the person has to be euvolemic. Yeah, the person has to be euvolemic. And then I look for urine sodium, and urine sodium has to be high. Okay, so if I find a combination of low sodium in the circulation and high sodium in the urine, and there is hypoosmolality and euvolemia, after I exclude all other causes for urine sodium to be high, what are the other causes for urine sodium to be high? Diuretic usage. I'll ask the person for diuretic usage. I'll ask the person for thyroid status. I'm not going to ask the person, I'm going to check. Yeah, I will check for thyroid status. The person has to be in euthyroid status. I will check for Addison's disease. After I exclude all these, I will say it is SIADH. Are you clear? So SIADH is a diagnosis of suspicion and exclusion. When will I suspect SIADH? When there is hyponatremia that is accompanied by hypoosmolality, that is accompanied by euvolemia with high urine sodium and high fractional excretion of sodium. After I exclude other causes for high urine sodium like diuretic usage and hypothyroidism and adrenal function, low function of adrenal gland, we'll say it's SIADH. When I told you about causes of euvolemic hyponatremia, I gave you 3 causes. One was SIADH, about which I've explained in detail. Yeah, and the second cause which I mentioned was hypothyroidism. So how does hypothyroidism present with euvolemic hyponatremia? It is because of 2 reasons. One is thyroxine has got a positive effect on cardiac muscle fibers. You know, it has got a positive inotropic effect on the heart. It has got positive chronotropic effect on the heart. That's basically thyroid increases heart rate, it increases force of contraction. Yeah, it increases heart rate, it increases force of contraction. So what happens in hypothyroidism? In hypothyroidism, heart rate is reduced and stroke volume is reduced. So when heart rate and stroke volume is reduced, cardiac output is reduced. So there is a decrease in the intravascular volume. Okay, there is a decrease in the intravascular volume. And apart from this, thyroxine is found to suppress vasopressin secretion. Yeah, thyroxine is found to cause suppression of vasopressin secretion. So in hypothyroidism, what do you observe? In hypothyroidism, there is a decrease in the intravascular volume. And we know the story from here. Whenever there is decrease in intravascular volume, you know, renin-angiotensin system gets activated. And hypovolemia and hyperosmolality stimulates vasopressin secretion. So renin-angiotensin system causes sodium and water reabsorption. Vasopressin causes only water reabsorption. So basically there is an increase in the free water reabsorption that causes hyponatremia. And additionally, thyroxine suppresses vasopressin secretion. So hypothyroidism, there is an increase in vasopressin secretion. So all these would contribute to hyponatremia. It's more or less like SIADH. So it presents as euvolemic hyponatremia. So that's about euvolemic hyponatremia. Now about hypovolemic hyponatremia. And hypovolemic hyponatremia will be because of loss of body fluids from any source. Loss of body fluids from any source can be for vomiting. So why does vomiting cause hyponatremia? Yeah, one is volume. There is a decrease in the intravascular volume. That's one cause. And the other cause is HCl is lost. Yeah, when HCl is lost, it causes metabolic alkalosis. And when it causes metabolic alkalosis in the kidney, yeah, bicarbonate has to be filtered. To avoid metabolic alkalosis in the kidney, bicarbonate has to be filtered. And bicarbonate, when it is not getting reabsorbed, it gets lost along with sodium. So sodium is lost even through urine and vomiting. So vomiting is a form of hypovolemic hyponatremia. Not only vomiting, it's diarrhea, diuretic usage, sweating, pancreatitis wherein fluids accumulate in the extravascular space. So all these would present as hypovolemic hyponatremia. And all these hypovolemic hyponatremia, as I said, urine sodium will be less except when the sodium is lost through kidney. Yeah, when is sodium lost through kidney? Whenever diuretics are used, and even in some forms of vomiting, urinary sodium can be high. Okay. So how do we identify the cause of hyponatremia? It's just a summary. We have discussed almost everything. So summarizing, whenever you find a case of hyponatremia, you should look for 4 parameters. The first one is serum osmolality. Second one is you should check the hydration status of the person. And the third is urine sodium osmolality. Okay. And with this, we will be able to make diagnosis of cause of hyponatremia. So as I said, osmolality, if osmolality is high, then it is dilutional caused by hyperglycemia or mannitol or radiocontrast dye. If osmolality is normal, it's a measurement effect caused by indirect ISE. Causes can be hyperlipidemia or hyperproteinemia. If osmolality is low, then it is true hyponatremia. If it's true hyponatremia, you should look for hydration status. And if hydration status is high, it's hypervolemic hyponatremia. Causes are many, but to find out a probable cause, you should look for urine sodium. Yeah, if urine sodium is less than 20 milliequivalents per liter, it is one of the causes of hypervolemic hyponatremia other than chronic kidney disease. So what are the causes I said? Congestive cardiac failure, liver cirrhosis, nephrotic syndrome. That is if urinary sodium is less than 20. If urinary sodium is more than 20, then the kidneys are not good to reabsorb sodium. So sodium is found in urine, so it's chronic kidney disease. And if hydration status is normal, then I will again look for urine sodium. And if urine sodium is less than 20 milliequivalents per liter, then it is hypothyroidism or psychogenic polydipsia. If urine sodium is more than 20 milliequivalents per liter, then it is SIADH. If it's hypovolemia, again I look for urine sodium. If it's less than 20, then it is loss of sodium through some other route. Example will be vomiting, diarrhea, sweating, pancreatitis. If urine sodium is more than 20, then it is diuretic usage or hypoaldosteronism. Okay, so this is the summary of hyponatremia. And this I've already told you. I thought I'll finish with a practical example, but I told you about a 50-year-old woman, a known diabetic, was admitted with altered sensorium. Her random blood glucose was 979 milligram per deciliter and serum sodium was 134 milliequivalents per liter. What is the probable cause of altered sensorium? Hyponatremia, pseudo-hyponatremia, hypernatremia, hypokalemia. So as I told you, for every 100 milligram per deciliter increase, why does Ganesan think of pseudo-hyponatremia? For you to say it's pseudo-hyponatremia, you should do the correction factor and check if it's really low, normal or high. So look for correction. So whenever blood glucose is more than 140 for every 100 milligram per deciliter, I said if it's more than 400, the factor is 2.4. So for more than 140 milligram per deciliter, it is 980 in this person. So how much has it increased? It has increased by 840 milligram per deciliter. For 100 milligram per deciliter increase, more than 400 milligram per deciliter, I said the factor is 2.4. So for 840, it is 8.4. So let me have it as approximately 2.5. Yeah, so it is 2.1. Am I doing it right? 21. So if you add it here, 21, it is 155. So it's 155. 155 is high sodium, right? It's 136 to 145, which is normal. So corrected sodium is 155. So what is it? It is hypernatremia. Okay, thank you.